Thank you, Donna. Appreciate that introduction. I feel a little bit like the choir lecturing in the pulpit, talking to Sapa today. I hope the next 50 minutes will be useful, not only to the practitioners, but to more importantly, to their patients that suffer. I want to salute everybody that's tuned in this morning because it sounds like it's been quite a long march. This is the closing day. The finish line's in sight, and it sounds like you've had an incredible amount of education. So with no further ado, we'll march forward. I've been tasked to present some information on post-traumatic stress disorder. I think the secondary topic, not all wounds are visible, maybe says it all. We're going to hopefully break this down into three elements: PTSD, moral injury, and traumatic brain injury. And this is rather dated information, please forgive me, but I think even though it's dated, it sort of cements the urgency of this topic. Back in 2012, there were more military deaths by suicide than in combat. Holy cow. Back in that point in time, military suicides were at an all-time high. You might remember the famous 22 a day. And it certainly looked like, fully a quarter of the folks that had been deployed in Iraq and Afghanistan had experienced a traumatic brain injury, which only complicates and worsens PTSD. On a national scene, 20% of suicides have been completed by veterans, and that's just a number that, as clinicians and caregivers, we can't live with. And then last but not least, there's 1/3 of a million veterans from the desert wars that had already been diagnosed. So I think this sort of highlights the urgency of this illness. Let's begin with a couple of case studies. These will be little reference points for us. No doubt they'll probably strike you as familiar from your experience in clinics and in hospitals and in the trenches. So case study one is a emergency room nurse who presents with a 2-month history of sleeplessness and irritability. She reports she's using more substances than ever before, and she's suffering from flashbacks because her husband came to work a couple months back with a shotgun and threatened to kill her over a dispute they had. Luckily, security was called and he was disarmed, but this event continues to reverberate. And at the visit, she's looking like she's in the midst of a panic attack. She's diaphoretic, she's tachycardic because her pupils are dilated. She's struggling to breathe, just kind of giving you the chief complaint. Case study two is, I think, a little more ominous, perhaps. This is a 32-year-old ex-Marine Iraqi veteran with a 5-year history. So this illness has been really ravaging him, of recurring flashbacks. There's the flashback piece, nightmares, suicidal ideation, and depression. After he fired on a vehicle that refused to stop at his checkpoint, it turns out that he ended up killing a pregnant Iraqi woman and her husband, who was unarmed and just fleeing from violence on the other side of the line. So the ramifications from this event is his marriage is ended. He's not able to hold employment. He's self-medicating quite actively with all manner of drugs and alcohol, and he's had multiple hospitalizations. So you just step back and look at these two souls, and they're clearly quite wounded from trauma. So here's our outline. We're going to be ambitious in these 50 minutes. Take a quick glance at the history, really spend time fleshing out the DSM-5 criteria to make the diagnosis. We'll look at the biology, epidemiology, and genetics, and then talk about assessment, differential diagnosis, and then treatment, non-pharmacologic and pharmacologic, and devices, and then a wee bit on what the future holds, and then talk about moral injury and a few takeaways. So here we go. So historically, this is in the United States. The literature is pretty sparse until the Civil War, when a condition called soldier's heart was described. In reading this condition, it sure smacks of PTSD. And then in the late 1800s, with railroad transportation beginning, there were numerous accidents, and quite often accident victims seeking litigation would report what they called spinal shock, recurring flashbacks of the accident. World War I, the label was shell shock. These were veterans that returned home, and they thought that they were damaged because of exposure to constant artillery bombardment. 1941, a very famous nightclub, the Coconut Grove in Florida, a fire broke out, and hundreds of people were in at the time, and they rushed the doors and weren't able to open them. They actually opened in instead of out, and many died, many were burned, and the survivors certainly reported PTSD-like symptoms. And then in World War II, you've probably seen that famous painting of the 1,000-yard stare. Combat neurosis was the term used for combat veterans, concentration camp, and atomic bomb survivors. But really, Vietnam was a tipping point. That's when PTSD kind of came to full bloom, if you will. And it appeared that the disorder correlated mightily with the severity of the trauma. But despite that lengthy history, it wasn't until 1980, so 40 years ago, in the third edition of the DSM, we have 5 now, the PTSD criteria was defined. So it's kind of a long time coming. Overseas in Europe, a little different picture. They talked about something called nostalgia or homesickness. These were in the Central European wars in the 1600s. And then in Spain, a condition called estar roto, a translation to be broken, which I think really poignantly implies what PTSD does to people. And then, of course, what we just covered, soldier's heart, shell shock, combat exhaustion. And then in the first DSM-1, which was published in 1952, my birth year, 68 years ago, stress response syndrome. This is probably describing returnees or returnees from World War II and probably the early point of the Korean War. So it's taken a long time for PTSD to kind of be defined and studied, and now we are in full blast with this serious injury. So for purposes of discussion, we're just going to look at military stress injuries, and this is a nice, I think, little breakdown. We have someone in the midst of combat or operational stress, and they either become injured or they adapt. Adapt is positive behaviors, coping behaviors, with some negative behaviors, but stress injuries kind of take the form of, trauma that leaves folks replaying the episode over and over again. Operational fatigue, sort of the long haul here of the day-to-day grind and wearing down of sleep deprivation, always being hypervigilant. And then probably most critically, grief, the loss of friends and leaders and witnessing their loss. And then something that we're only now are beginning to kind of look at, but it probably bears as much importance as the other 3, moral injury, where we have been exposed to a trauma that is not part of our culture. We've been exposed to an event that actually violates moral values that we've all been taught and grown up with. So that's one little kind of, I guess, way to look at military stress injuries. Kind of broadening it out to the civilian world, we have normal functioning, then a traumatic event, whether it's domestic violence or violence on the street, and all sorts of outcomes here for the injured, be it confusion, shock, denial, hesitation, and certainly the centerpiece is shock and denial lead to intrusive thoughts, attempts to process the event, and if we're lucky, normal functioning. So let's lean into the diagnostic criteria DSM-5, published 5 years ago now. So it kind of requires the big five. First off, there has to be exposure to a serious threat. And then this is followed by intrusion, re-experiencing the event long after it's physically over, and then avoidance of any cues or clues that suggest that event. And then the fourth bullet really is sort of a mood piece, negative alterations in cognition and mood. Hard to think fast, think correctly, and everything is negative. The joy of living is gone. And then last, but certainly not least, there's really a dramatic and consistent alteration in arousal. This is the hypervigilance, if you will, the startle reaction. The duration of these symptoms has to be at least a month. Anything less than a month is simply called an acute stress response. So this is longstanding. You remember our 2 case studies, the nurse where the symptoms have been going on 2 months, the Marine where the symptoms have been going on for 5 years. Like any illness, any medical condition, these symptoms, this disorder has to cause distress and affect ability to function either socially or occupationally. And these symptoms can't be due to substance abuse, another medical condition, or another psychiatric condition. So now kind of taking a deep dive on these criteria. So exposure. So this is exposure to actual or threatened death, serious injury, or sexual violence. In DSM-4, this was defined as an event that you're exposed to that's beyond ordinary human experience. So this is a little more fine-tuned. And it has to be one of the following 4. You either directly experienced the event, or you witnessed it, or you learned that it happened to a family member or friend, or you experienced repeated exposure to aversive details of the traumatic events. There's a lot of argument about this. What if you saw it on TV? And of course, in the last year, I think we've all been exposed to significant traumatic events. I would say repeatedly, maybe incessantly, but that did not get the go-ahead sign for DSM-5 exposure. So intrusion after the event, presence of one or more of these intrusive symptoms. So recurrent involuntary and intrusive distressing memories of the trauma. So you're going about your day and out of nowhere, it's in front of you and it's live. And of course, recurrent distressing dreams, usually combat nightmares, if you will. Dissociative reactions, where you actually flash back. You are in the trauma again, full on, physically, emotionally. And then intense distress, exposure to cues. So the Vietnam veteran that sees the hospital helicopter take off the air life helicopter, and just hearing the rotation of the blades takes him back to 1966, a hot landing zone in Vietnam. So intrusive symptoms, one of the following 4. Avoidance. So this is a persistence avoidance of anything associated with the traumatic event. And this can be sometimes quite distant. So we want to avoid any memories, any thoughts or feelings associated with the event. So this is the veteran that's sitting at home and watching the evening news, and suddenly there's a story about recovery of remains from Vietnam. And immediately it all comes rushing back. and avoidance of or efforts to avoid external reminders. So this is the usual people, places, things, conversation that arouse these distressing memories, thoughts, or feelings. And sometimes I think folks that have PTSD are ambushed, just ambushed out of nowhere. Something as simple as just perhaps witnessing maybe a memorial service. They're just ambushed. The fourth criteria is negative alterations in cognition, mood. This is where PTSD in many ways looks a lot like depression, and you can just see the symptomatology here, 2 or more, inability to remember an important aspect of the trauma. This is kind of puzzling. They remember everything but a very significant piece. We're not sure we understand this mysterious piece, but it's quite often there. And then a lot of negativism about yourself, about the world. You know, this is a bad, evil place. Nothing good happens, and I'm part of it, and I'm to blame. Distorted cognitions about the consequence of the trauma. If I hadn't have gotten up to rush the enemy, my best friend, whose head I watched disintegrate, he wouldn't have gotten up either. Just persistent negativism. There's nothing positive in life, in the world, in our family, in our job. Bullet 5, anhedonia, loss of interest in things that give us joy. And then bullet 6, this is where I think folks are really quite damaged. There's just this detachment and estrangement from people that love them. And then an inability to have positive emotions. I mean, you kind of read this list and you say, this is just a horrible way to trudge through life day after day. And then in closing, the last criteria, marked alterations in arousal. So this is the exaggerated startle response, bullet 4, but it also kind of spills over hypervigilance. I treated a fellow here in Texas who every night walked the perimeter of his house for an hour before he could lock the doors and go to sleep with his AR-15 at the bedside. So hypervigilance and exaggerated startle are what we see a lot, but part and parcel of this criteria is sleep disturbance. My goodness, this is incredibly comorbid. And problems thinking straight, concentration. Of course, you also see a lot of irritability and outbursts. This is very troubling to coworkers and family. And then bullet 2 is really where people destroy themselves, that reckless or self-destructive behavior that we saw in the Marine. So we know a lot about the biology, looking at a normal stress response and then looking at a stress sensitization response. We can see normal subject with major depression, subject with PTSD. Beginning in the hypothalamus, we have the threat. There's release of CRF in the anterior pituitary, which leads to release of corticotropin. And then our adrenals release cortisol. So, the peptide for us to either fly or fight. And then we get a feedback loop to shut it all down in the normal subject once the threat is gone. Patients with depression, you can see that things are a bit magnified to a threat over on the left, greater stimulus, if you will, and greater stimulus of cortisol. But the feedback loop to shut it down is almost non-existent to a degree. And then patients with PTSD, again, very magnified initial CRF response, very little corticotropin. And really, here's the key, very little bit, just a tiny amount of cortisol with exposure to this trauma or this memory of this trauma, and then this exaggerated shutdown. So this system is dysregulated. The best metaphor I can give you is if you buy a burglar alarm system for your house, the window panes are set to alarm if a burglar jacks them up with a tool. But the window system is not set to alarm if the wind blows vigorously and vibrates the glass. Well, with PTSD, the alarm system goes off at the slightest hint. So further reinforcement of that piece. The biology is pretty clear cut in PTSD patients. If you collect a 24-hour urine, what you see is dramatic elevations in epinephrine. That's our stress hormone, if you will. It activates us, fly or fight. We also see decreased alpha-2 receptors. In the HPA axis, again, very, very low plasma and urinary cortisol levels. And when we do a dexamethasone suppression test, which we thought was predictive of depression, but had too many false positives, what we see is dramatic suppression of cortisol. So we can kind of identify folks with this disorder biologically. I won't belabor this topic. Here's a kind of this is a much larger scheme. In the center of dysregulation is that large yellow circle or gold circle in the middle, the amygdala. So the amygdala is our fear regulator, a very primitive mechanism designed to keep us alive within nanoseconds of a threat. And you can see on the left, there's a stimulus, there's a trauma. It's perceived, it's processed through the neocortex, but it very quickly is sent over to the amygdala, where we see all sorts of responses. In the upper left, there's a startle response, ventral medulla. We may actually freeze at this event, regulated through the DMN of the vagus. We get changes in our parasympathetic nervous system. But what we most commonly see is through the rostral medulla, where dramatic activation of the sympathetic nervous system. So this is a dysregulated warning system and dysregulated in the fear center of our brain, the amygdala. So there's some ideas about biology, and perhaps early life stresses. I don't know if you use in your clinic the ACER questionnaire. It's the Adverse Childhood Experience Rating Scale. It really gives us a laser beam look at early life stresses. But there's some evidence that perhaps early life stresses may actually start to dysregulate this axis even before what we call the incident trauma. There's some evidence that perhaps folks that are more vulnerable to this disease have some changes in their hippocampus. That's our association memory in the medial temporal lobes. There's also some evidence that in this population there's decreased BDNF. And BDNF, we think, is a really important transmitter, if you will, for neuroplasticity and for cellular neuronal repair. So if you have a diminished level of it, that makes neuronal repair and plasticity dysregulated. And this can be expressed either as a hypo or hyperactive stress response. Now, where this notion kind of struggles with is Oprah. So I don't know how many of you are familiar with Oprah's earlier life as a child and a young girl, but I'll just simply say it was beyond horrific. The traumas that she experienced were numerous and long-standing, yet she survived, she thrived. So one of I think the good things that's come out of this horrible disease is looking at a condition of post-traumatic growth, looking at resiliency. Is it possible to build in or design in resiliency? Can we create partial stress sensitization, yet prevent the development of PTSD symptomatology? So this is in its very early stages, its infancy, but certainly the military and law enforcement are very interested in this idea, given the work that those two services do. So the idea of resiliency. Back to early life events. This is one little notion. So you have early trauma, abuse, violence. That's the individual experience. And this kind of sets up some physiologic responses, both autonomically and neuroendocrine wise. And then it also leads to some behavioral responses. And again, here's sort of the neuroanatomical picture. I'd ask you to focus on the bright orange amygdala, but you can see its connections to the hippocampus association memory. That's why cues can kind of set the alarm system off. You can see its connection to the prefrontal cortex. That's why folks with PTSD have difficulty with cognitions. And then, of course, the anterior cingulate cortex, that's really where our alarm system kind of lives and is activated in terms of actual symptoms. So finishing this piece out, in kind of a short summary, what we know about PTSD is certainly the amygdala has increased and overactive activation in response to anything that remotely resembles the trauma. On top of that, it looks like the medial prefrontal cortex, this is where we think and process information, that's actually slowed down. That has decreased activation. And then last but not least, in our hippocampus, there's some real problems in terms of putting memories in the right places and recognizing when contexts are safe. So genetically, we've been able to, I should say the geneticists have been able to identify some genes that they think may make a population more vulnerable. You can see that they all have different links to different neurotransmitters. And if we put the picture together, so you're born with a certain set of genes that might predispose you, and then you have early adverse childhood trauma that kind of sets you up even more, and then an incident trauma, Tom the Marine firing on unarmed civilians, and then PTSD symptoms is sort of the kind of what we think is the whole sequence, if you will. So towards this resiliency gene, one of the studies that's ongoing is there a resiliency gene? Can we isolate it? Can we maybe use some transcriptase RNA and activate it in folks that are perhaps getting ready to be exposed to trauma? What we do know is that when we activate the medial PFC in mice that are learning mazes and getting shocked along the way, that when we activate this medial PFC, they become quite helpless. So we're looking for that gene that may do just the opposite. Epidemiology. Some good news, not on the slide. We think that maybe 70% of the world population in their lifetime may have exposure to an event that's traumatic. But of that 70%, only about 6% will actually manifest the full-blown PTSD disorder. So the good news is many are exposed, but not everybody develops the condition. Furthermore, we have some interesting data that maybe 44% of folks that are diagnosed with PTSD over time recover, if you will, spontaneously. So the folks, the patients that you are seeing and you are treating are those unlucky folks that had traumatic exposure and are not recovering. So here's epidemiology. So lifetime prevalence, 1 to 3% of the general population. I think I just quoted a little higher figure. We can see that there are certainly high-risk groups, Vietnam veterans, for example, can appear at any age, but the young are more vulnerable. Women, twice as much as men, depending on the trauma exposure, which quite often is rape or domestic assault, but that's changing now with women serving in combat units. And then PTSD is also more likely to occur in those folks that but maybe have less support, if you will. They're single, they're divorced, they're widowed, they're isolated, they're economically handicapped. Of course, you think about isolation in the pandemic, no doubt that's made all of our jobs more challenging and difficult, and really, I think, brought more suffering to our patients. So assessments. So these are paper and pencil tests. There's a number of them. They have their pros and cons. Since I'm talking to Army PAs, no doubt you're familiar with the CAPS. This is sort of the gold standard. Gives us a number, a 30-item structured interview. It just kind of follows the DSM-5 criteria. There's something used in primary care that's very short, more of a screen than anything else, just 4 items to kind of, sniff it out, if you will. Then there's a post-traumatic stress disorder checklist. This is kind of in the mid-range, 19 items, 0 to 4. Again, it gives us a cutoff score. And then there's a post-traumatic diagnostic scale. This is much longer. It kind of really fleshes out trauma history in 2 different parts, and then also fleshes out PTSD symptoms, and most importantly, looks at function. How is the patient with PTSD able to function socially, occupationally, within their family? And then out of the University of Davidson, kind of a short, quick hitter, the Davidson Trauma Scale. So these are all checklists done with the clinicians. Some of them are also done by the patient to kind of give us a number. We love numbers in medicine when we're trying to seek a diagnosis. So comorbidity, this wouldn't be a decent presentation if we didn't just take a minute and sort of take in the massive comorbidity that this disease brings with it in its wake. It's incredibly high for psychiatric syndromes, depression, bipolar illness, GAD, panic disorder. But what's truly most likely are substance abuse disorders. You can imagine if you wake up with a combat nightmare and you want to get back to sleep, you'll take almost anything to try to put yourself into oblivion. So comorbid substance abuse and conduct disorders are more often seen in male patients than female patients, but the substance abuse is going to be immense. Now, we also see an incredible co-occurrence of PTSD and TBI in Operation Iraqi Freedom, Operation Enduring Freedom veterans. 50% of them have co-occurrence of TBI, be it mild, moderate, or severe, and PTSD. And then downstream, so these are our older veterans, our Vietnam veterans, our Korean War veterans. Most of our World War II veterans are in the next life, but we now are kind of putting 2 and 2 together that suffering from PTSD seems to put them at greater risk for earlier onset and more severe neurocognitive disorders. So this illness is a package deal. It by itself is incredible suffering, but the comorbidity is just immense. So given that, what's a clinician to do if someone presents, a new patient presents to your clinic, and their chief complaint are depressive symptoms or anxiety symptoms or panic symptoms like our nurse in our case vignette? Of course, we want to do due diligence, and we have limited time in our assessment. And these are some of the differential diagnoses that folks with PTSD it may stimulate you to think about them. Is this acute stress disorder? Are the symptoms greater than a month in duration or less than a month? Is this just major depressive disorder and we have sort of a PTSD overlay? Is this some type of anxiety disorder? Typically panic disorder comes to mind. And perhaps if they're marching the perimeter and checking their door locks 50 times a night, we'll think about OCD. Is this some type of serious adjustment disorder? If the patient's chief complaint is about flashbacks, do we think that they're dissociating? Is this a personality disorder because of their irritability and outbursts and reckless behaviors? Sometimes are the flashbacks of such a degree that we might think this is a psychotic disorder, or is this some type of conversion disorder? And I neglected to put down another bullet. Is this some type of malingering? So the differential diagnosis is broad, very broad. And these are things that you're going to consider based on the symptoms that the patient presents to us. And then, of course, as you go through your CAPS checklist, you might be able to start to fine tune your diagnosis. So treatment, PTSD. We'll talk about non-pharmacologic and pharmacologic because it's pretty clear from the literature and the ongoing research that first line, when you make the diagnosis of PTSD in your patient, first line treatment is exposure therapy. Right now, what's kind of developing is virtual reality therapy, but truly what this is about is trauma-focused therapy, cognitive restructuring. I think in your clinics, you probably have special resources for that. Perhaps you yourself are trained in this, but this is first line. The problem with this is it's laborious. An awful lot of people struggle with it. There's a fairly high dropout rate, but this appears to have a much bigger effect size on patients with PTSD than medications alone do. Second line therapy is EMDR. This takes some training for the patient, but appears to be something that they own and can use on their own outside of clinic visits. Something called stress inoculation. This has to do with, can we kind of build in resiliency before the young troop is exposed to trauma. And then acceptance and commitment therapy is really sort of reserved to treat the moral injuries from PTSD. And then third line, but I think I'm the sort of clinician that's pragmatic. I'll take whatever works as long as it's not illegal or destructive. But third line is the dialectical behavior therapy created by Marshall Linehan. That's first line for treatment of borderline personality disorder. And then, of course, sort of yoga and mindfulness. I think one of the reasons they're helpful is they kind of retrain through breathing exercises and decrease that stress sensitization response. So these are all first line non-pharmacologic first, second, and third line non-pharmacologic recommendations that I have no doubt in Army clinics you either have direct access to them or direct access through them through your civilian counterparts. And they are, I think, very evidence-based. So I think the way I view PTSD is we know that non-pharmacologic has greater effect sizes, but we also know that medicine is helpful. So I'm always a big fan of thinking about combination therapy, pharmacologic and non-pharmacologic. The FDA has only approved 2 antidepressants out of our 32 FDA-approved antidepressants, and that's Paxil and Zoloft. There's a number of SNRIs that appear to be useful, some that actually may backfire, like Cymbalta. In terms of second lines, believe it or not, older drugs have had modest effect sizes, older tricyclics like dazipramine, and MAOI, phenelzine, Nardil, has had evidence-based small effect sizes. Gabapentin, I think, now is a bit controversial because it's become the darling in the opioid epidemic, but there's certainly been some mildly positive studies. And benzodiazepines, this is always, I should probably put this in a flashing red beacon. There is a utility to benzodiazepines in PTSD, but it's usually very short-term And it's usually when everything else fails. And it also comes with great cautions. In terms of adjunctive medicines, naltrexone has oddly enough been utilized for PTSD. The sedative hypnotics are kind of a long and colorful history. I think what most clinicians rely on, particularly in the Department of Defense, is trazodone, which is actually kind of an off-label hypnotic and a first-line antidepressant. Lamictal is a mood stabilizer. It's only FDA approved to prevent relapse of depressive episodes, but there's some intriguing evidence that maybe Lamictal may have a place in PTSD. Mirtazapine, a very unique heterocyclic antidepressant that has some remarkable sedative properties, but also comes with weight gain. And then the second generation antipsychotics, these would be Zyprexa, Seroquel, and Risperdal. I think these are usually reserved, I won't say last resort, but reserved for those PTSD patients that manifest such dissociation and flashbacks that they appear psychotic. And then last but not least, although I know that of late, there's been some research that suggests prazosin may not be all that we thought it was, but this has been used for decades for nightmares. So here's a non-psychotropic medicine used to control combat nightmares. And where this comes from is, as we mentioned, biologically, veterans with PTSD, what you'll see in a 24-hour urine is just massive elevations of norepinephrine. So we know that norepinephrine is in the nucleus raphe. Once it's triggered, we're going to get activation in terms of shaking, sweating, tachycardia, and hyperarousal, if you will. So towards that end, the question is there any way to kind of tune down that system? So prazosin, an antihypertensive, brand name Minipress, I'm not really sure how it came to pass that it was tried, but because it's an alpha-1 adrenergic blocker, perhaps a bright clinician said this might help. And lo and behold, in studies, it appears to normalize slow-wave sleep. And slow-wave sleep is really important to cellular repair, reducing neuronal damage. And it looks like when dosed at night, the combat nightmares certainly decrease or diminish. The dose is very broad, 1 to 20. I was just reading the last study that with prazosin where the dose was, average dose was 5.5 plus or minus 4 milligrams. So, but it's recommended that you tiptoe upwards and start at 1 or 2. Of course, because it's an antihypertensive, there's the potential for orthostasis and dizziness, and also GI effects. Typically, these attenuate with time, and it does have some drug-drug interactions, particularly with Lasix and other antihypertensives, but been used for a long, long time, particularly to help with sleep. Propranolol, here's a full-on beta blocker, another antihypertensive. And there's some intriguing work that if patients can be dosed pre-activation, if you will, so 90 minutes before exposure to a trauma, of course, how do you know when that's going to come about? But patients who have been pre-dosed, it appears that this dramatically reduces the development of PTSD symptoms. So something's going on in the central nervous system that kind of boots up that stress sensitization circuit using propranolol. TMS, transcranial magnetic stimulation. I don't know how accessible this is in the military. I think usually in the large centers like Walter Reed and so forth, it's relatively accessible. As you know, this treatment came about for treatment-resistant depression, and finally approved in this country 6 or 7 years ago. Now there's some really dramatic evidence that's quite helpful in different frequencies and in different settings for PTSD. We're looking at deep brain stimulation that also appears to be helpful. And in the interest of time, I know we've all heard about ketamine, lots of case reports with very dramatic, rapid outcomes, but not sustained outcomes. I think you'll see as time goes on, dextromethorphan, it used to be an over-the-counter cough syrup, but it's a glutamatergic agent that is much more easily delivered than intravenous ketamine. This may be of benefit. There's a nice evidence-based report with 50 milligrams of Seroquel that seemed to be very helpful for, particularly for nightmares and sleep problems. And then there's that another study where patients given a dose of steroids after trauma exposure had dramatically reduced PTSD symptoms. But I think where the money lies is in psychedelics. I hope you've all been exposed to some of the, I would say, well-nigh miraculous outcomes with a single exposure to an old drug in the 60s, MDMA, ecstasy, if you will. This is where a patient is certainly prepped ahead of time with psychotherapy. They receive a single microdose, and then they're with the therapist for 4 hours, kind of going through exposure therapy. And the outcomes are they are in robust, healthy remission, very functional, 2 years after a single exposure. So as you know, these drugs have been given a second chance, and I think we're all going to be finding them in our armamentarium in the not distant but near future. Stellate ganglion blocks, initially some evidence that might have been helpful. That's kind of fallen out. D-cycloserine, this is an old antibiotic that may have some benefits. And of course, it's everywhere now. Medical marijuana might be helpful for neuropathic pain. It is being studied, but of course there's all sorts of questions with purity and federal regulations. In the last minute or two, I want to talk about moral injury. So here we have a veteran who has been damaged physically. Maybe he has spinal damage from jumping out of helicopters or airplanes. Maybe he has a traumatic brain injury. He's physically damaged. He's emotionally damaged with PTSD. So we actively treat those two very evident injuries. But what often goes completely missed is a moral injury. So this is damage done to the patient's conscience. What a strange term to use in a medical lecture. And this comes about from either participating in or witnessing an act that's beyond our cultural and moral beliefs and standards. Witnessing a 3-year-old child being executed. And what this evokes is profound shame and profound guilt. And it often goes ignored because as medical clinicians, we have perhaps bigger fish to fry. But now that we're aware of it, you can see how often it's missed. There's a kind of a table comparing PTSD and moral injury. And really the folks that are extremely capable of handling this are the chaplains attached to the units, the chaplains' assistants. They typically work with moral injury on an individual basis and a group basis. And it's not overnight miracles, but just the fact that it's addressed and there's an awareness is by itself important. So little intersecting Venn diagram, PTSD symptoms on the left, a moral injury on the right, and then kind of the symptoms that they share, because of this, incredible grief, incredible shame, self-medication, anger. How did I let myself be manipulated that way? So where do we go from here? Well, I think, I'm waiting for the type of public awareness that breast cancer has for PTSD. I think we see the wheels turning, the momentum occurring. This is something that's been around since tribes went to war. And then maybe bullet 6 is the most important thing. Can we consider the moral injury impact before we go to war? So some ideas about how we heal from this, and I think I've got to wrap this up in about the next 1 minute. This is kind of the perfect PTSD outpatient treatment program in Denver. I'll let you go back and study this slide later on, but it kind of incorporates everything, medical, psychiatric, psychological, spiritual, and eligibility. You can kind of see the staff that they have, the ideal program. So takeaways, as I mentioned earlier, a large part of the globe will experience a traumatic event, but most don't develop PTSD. Hallelujah to that. But we take care of the people that do. Lots of factors are at play here, genetically, environmentally, particularly early childhood stressors. And this is a mighty painful disorder that has suffering not only for the patient, but their family, friends, comrades in arms, affects quality of life dramatically. First job is to rule out all comorbidities and treat them. Constantly be on the lookout to maintain substance-free so you can effectively medicate these folks. Be very proactive about sleep disturbances. I believe sleep is a medicine. First-line therapy remains psychotherapy. And then there is some evidence of effect sizes with SSRIs, particularly Paxil and Zoloft. Newer agents are in the pipeline. So I know that you've got 3 more lectures ahead before you can pat yourself in the back for a great learning experience this past week. I'll pause and happy to try to take questions you might have at 9 a.m. Eastern Standard Time on a Friday after the long march this week. Thank you.
Thank you so much, Dr. Weiss. This is really a remarkable presentation, and really appreciate you bringing to light some of those really key components we need to consider when dealing with patients with PTSD and trying to help them. One of the questions from the audience is, can you talk about strategies to improve resilience in people before they are exposed to decrease the possibility of getting PTSD? I think this really goes back to the inoculation therapy that you were talking about.
Golly, I can't. I'm going to profess that I just know really superficial details. There's a physician, a psychiatrist. His last name is Seligman. I believe his first name is Norman, and he's kind of the guru on resiliency. And he can go into chapter and verse and details about how we can build this in. I mean, not only into military folks, but into maybe all of us. Might not be a bad idea. How do we build resiliency in our children now? So I'm sorry that I'm going to fail you there. I don't know the details. I do know that I like the fact that this kind of springs forth from PTSD. Here's a horrible illness, and we usually, what captures our attention is how do we control the symptoms, but to think about it from another angle of attack, post-traumatic growth, how we can kind of maybe prevent. I mean, the one thing that I'm tortured by in psychiatry is we're a very early discipline, and now we have medicines and treatments. Hallelujah! For a long time we didn't, but we have no conversations about prevention, and that day's coming. That day's coming. But so the same piece goes here. So I think what I did there was say I don't know, and then gave you a lot of baloney. So thank you. But look up Norman Seligman. He wrote the book on resiliency, and I think he's actually a consultant for the Department of Defense.